Hi everyone, I am very honored to share this session about epilepsy. I'm Juliette Bouchereau, I'm a pediatrician specialized in metabolic disease in Necker Hospital in Paris. So we are going to listen three very great presentations, and we are going to listen in succession, so please reserve your question for the end, and we have some time for answering questions at the end of the presentation. And thank you very much to all the speakers. They are all neurologists and child neurologists specialized in epilepsy in a rare reference center. So first we will hear from Aurore Curie, who is a researcher and child neurologist at the Women, Mother and Child Hospital in Lyon. And she will tell us about the assessment of CTD patients with a study underway to find the relevant markers for monitoring and the evaluation of these patients.
Thank you so much. First, I would like to thank the organizer to give me the opportunity to talk about what we learned about epilepsy in the study where I already met several patients' families that participate in the study, so they can also say something about their experience. But what we learned about CTD patients' epilepsy in this study, so this study was designed to be able to determine the most relevant outcome measures, and it is called CREAT criteria. So as you all know, CTD deficiency is a creatine transporter deficiency is a rare X-linked genetic disorder related to pathogenic variants of SL6A8 gene. The first patient was described in 2001. And as you can see here in, in this figure, there is a strong correlation between the age at diagnosis and the year of birth, meaning that the patients that are younger are diagnosed now at a younger age nowadays. This is from our paper which has just been accepted in neurology. So the clinical diagnosis includes intellectual disability, autism spectrum disorder, and epilepsy. Roughly, depending on the different studies that were performed, half of the CTD patients have epilepsy. The second characteristic, as you know, is that there is an increased urinary creatine on creatinine ratio. And as you can see here, the difference is higher. The urinary creatine ratio is higher in males compared to females. There is also a severe decreased creatine peak in spectroscopy. As you can see here, you cannot see the peak of creatine, whereas here on a normal control, you can see it. And it's likely underdiagnosed, even if we can expect more diagnosis thanks to the new generation sequencing. So, in this study, we will include 24 male CTD patients with a pathogenic mutation in SL6A8, aged 5 to 35 years of age. So, what we did regarding trying to better understand the epilepsy was that we first did a family history, a very precise developmental trajectory. The families can testify that we asked them a lot of questions, and we did ask a lot of details about the development of the child. And then regarding the epilepsy, we did want to know the age at onset, the treatments that were used, the maximum number of treatments, the side effects that were reported, the number of hospitalization related to epilepsy, the seizure types, and with all patients, we again try to have a clinical description of the seizures, the seizure frequency and duration, and to see if there were pharmacoresistance. So then we performed a centralized analysis of EEG. So we did try to, as usual, characterize the fundamental activity and frequency, the presence or absence of sleep, the reaction of intermittent fatigue stimulation and hyperpnea. We did check if there was an ictal activity and if we could find interictal abnormalities, which could be focal, generalized, or both. And then I will finish with, in the methods and then the results, with the cognitive impact of epilepsy using a scale which is a lighter scale. Maybe you remember in our previous study we did try to use the Wechsler scale, and unfortunately not like 75% of the CTD patients were not able to have this scale, whereas here with the lighter 3 scale we were able to have an IQ for all patients included up to now. So it's very interesting because it was not possible with other scales. This scale allows you to compute a nonverbal IQ with 4 subtests. So it's just some example. Here you have to identify patterns on a global picture. Here to recognize a whole object from a fragmented image. The third subtest is to categorize objects or geometric design. You have to see the apple is in the same category as the banana. And the examiner makes faces and expression that helps the patient to understand what he has to do. And then also they have to sequentially order the design, so you have to select this picture. So what did we find? So we were able to analyze 35 EEG records from 15 CTD patients. So first, the fundamental activity was normal in 32 out of the 34, 16 with alpha and 16 with theta, which was normal because of the age of the patient. It was abnormal in 2, 1 was delta and the other one was theta. We did check that they were able to have a sleep recording in 18 patients, in 18 recordings. And we did notice 11 records with rapid rhythm. It's interesting, and I will show you a picture in a moment. Then 18 out of the 34 did have the intermittent fatigue stimulation, and only 1 showed activation during fatigue stimulation. No seizure was recorded, and what is very interesting, I think, was the fact that we observed in 50% intellectual abnormalities, and especially focal abnormalities, only 12 in 82%, focal ungeneralized in 12%, and only in 6% generalized abnormalities. So here you can find some examples about focal abnormality here on the central right area. Here an example of a generalized, I don't know if you can see my little light. Yeah. So here you have a generalized wave spike abnormalities. Here you can see the rapid rhythm, which were not related to benzodiazepine. And here you can find other, sorry, rapid rhythm and a central spike during sleep. And to finish, here you can see the focal abnormalities here on the temporal electrodes, and you can see that there were on the right focal activity on the temporal region. So clinically, we checked also if they had febrile seizures, and it seems that CTD patients have a higher risk of having febrile seizures, which happened at a normal age, at 24 months, mean age. So then the epilepsy characteristics. So we, in our first 15 patients that we analyzed, we had 10 out of 15 patients with epilepsy, so meaning a little bit higher than what we had before, 60%. What is interesting is that the age in the group with epilepsy and the age in the group without epilepsy was very similar, as you can see here. So, because I will show you a comparison after, so it's interesting. The age at onset of epilepsy was 7.5 years. And you can see here that all patients with epilepsy were at least hospitalized once relating to their epilepsy. The mean number of hospitalization was 2 from 1 to 3, so not so many. And the maximum number of anticonvulsant treatments, you can see here that there was a majority of mono and B therapy. Only 3 out of 10 had 3 therapy of more at the maximum number of treatment that they had. Interestingly, we noticed that 2 patients had very unusual, I would say, side effects related to benzodiazepine. 2 had aggressivity and violence outbursts, I mean, something really kind of drastic. They destroyed the wall, they destroyed glasses, and the other one, he just, in the classroom, he took the bench and threw the chair at the other. And it is not at all like that usually. So it's very interesting to see that we noticed that in 2 patients. So maybe we could be a little bit more cautious about using benzodiazepine, even if it works on seizures, of course. So we also checked the present anticonvulsant treatment, and you see that they were able to stop anti-epileptic treatment in 3 out of 10, but 4 out of 10 had B or 3 therapy. We noticed 3 out of 10 patients with epilepsy that had status epilepticus, and all of them had inaugural, so they start their epilepsy with status epilepticus, which was, of course, difficult for the families. The seizure types, so half of them were focal, 2 only were generalized, and 3 were unknown because the parents were not there. I mean, they were alerted by the noise when the crisis generalized, so we cannot be sure. But it seems that a lot of CTD patients have focal seizures. And to finish, the pharmacoresistance, 4 out of 10 were pharmacoresistant, and 1 was with unknown status because the optimal dosage of the drug was not reached. And to finish, this result about the impact of epilepsy on the IQ, of the nonverbal IQ, you can see here that it seems, and of course it needs to be confirmed on a larger cohort, but it seems that CTD patients with epilepsy, in pink or red, have a lower IQ compared to CTD patients with no epilepsy. So to conclude, I think that we showed here that we noticed a lot of focal abnormalities and focal onset regarding epilepsy in CTD patients. 30% of epileptic patients had status epilepticus, which was inaugural in all cases. The side effect of benzodiazepine, I noticed before, and it might impact cognition. Of course, this needs to be replicated on a larger cohort. I would like first to thank all the patients, their families and caregivers, and all my collaborators, especially Mathilde Papatanasiou and Joseph Toulouse, to help me with everything. Thanks a lot.